This is Michael Secco from Stony Brook University Hospital. This is the SAEM lecture series, and I'm here to discuss regional anesthesia of the upper extremity. Here is the overview for this lecture. I find regional anesthesia has growing utility in the clinical setting as an alternative to opiate analgesia. I'll be discussing the indications, the technique, and sonoanatomy of forearm blocks, covering the median, ulnar, and radial nerves. We make these choices all the time. What if we have a patient with an upper extremity injury, such as a fracture or dislocation? I have multiple options to treat this injury. Should I inject the joint, sedate the patient, perform regional anesthesia, or just give some opiate medication? Or what about that heroin addict that has a large abscess on their arm? Can I perform the IND under just local anesthesia, regional anesthesia, or does he or she need to be given moderate sedation? Performing moderate sedation is within our purview. However, we know there are some drawbacks, particularly they require both time and resources. Performing moderate sedation requires extensive monitoring both during and after the procedure, depending on the sedative used. Sedation also requires the use of other hospital staff, especially a nurse, who is already burdened with a million other patients and orders too. There are inherent risks to moderate sedation, including respiratory depression, depending on the medication used. Also, procedural sedation is known to increase the length of stay of your patients and keep that stretcher from another patient who has been waiting for quite some time in the waiting room. There are multiple advantages of using ultrasound guidance for regional anesthesia. Ultrasound's biggest advantage is allowing the sonographer to visualize the anatomy of each individual patient. Not every patient will conform to the anatomy we are taught during medical school. Ultrasound will allow the sonographer to view the nerve in its entire course. Ultrasound will also allow visualization of the needle and ensure proper placement of the anesthetic agent to the nerve and not inside the fascicle bundles. In addition, ultrasound reduces anesthesia's failure and reduces adverse outcomes such as vascular injury or even pneumothorax. Length of stay are markedly shorter, too, compared to sedation. The nerve bundles or fascicles themselves are fluid-filled and have an internal hypoechoic appearance compared to the surrounding epineurium, which is hyperechoic in appearance. This gives a nerve a honeycomb appearance on ultrasound. Nerves will appear more hyperechoic with respect to adjacent vessels. The hypoechoic fascicles are more prominent in some locations, particularly as you scan more proximally. Here I have a clip of my own median nerve. Notice when I fan how the nerve becomes more hypoechoic and blends in with the surrounding muscle. But when the probe is perpendicular to the nerve, it becomes more hyperechoic and is better visualized. This change in appearance, based on the angle of the probe to the structure visualized, is called anisotropy, and nerves, as well as tendons, exhibit this type of property. Here is an actual case that I saw in the emergency department, and I have seen a few times as well. A patient presents after a table saw injury and has multiple lacerations to all 5 digits, including, in this case, a partial amputation of the 4th and 5th digit. To perform a digital block for each digit would be time-consuming, and how can a provider anesthetize if the amputation is near the MCP joint? The emergency physician performed ultrasound-guided blocks to both the radial, ulnar, and median nerve right at the bedside. This patient was quickly evaluated without any discomfort by our hand surgeon and taken immediately to the operating room for operative repair. Forearm nerve blocks work very well for complex injuries to the hand, including multiple lacerations to 1 or more digits, such as we saw in the previous slide, work well for finger amputations, puncture wounds, or fractures of the hand or digits. Here's a schematic drawing representing the sensory distribution of the median, radial, and ulnar nerves to the hand. As you can see, the median nerve supplies the thenar eminence, the palmar aspect of the 1st through 3rd digits, and the radial side of the 4th digit. Also note, the median nerve extends to the dorsal side of the aforementioned digits up to the PIP joint. The ulnar nerve, highlighted in yellow, supplies the hypothenar eminence, both the palmar and dorsal side of the fifth and the ulnar side of the fourth digit. The radial nerve, highlighted in red, supplies the dorsal side of the first through third digits. Preparation is key to any procedure, and choosing the right equipment is vital to a quick and successful procedure. Since we are trying to view superficial structures in the forearm, we should use a high-frequency linear array probe, somewhere in the frequency of between 13 and 6 MHz. Also, a 22 to 25 gauge needle would be sufficient as well. I tend to use the 22 to 23 gauge needle. I find the 25 gauge needles to be too short, unless the nerve is very superficial. If you have access to a nerve stimulating needle, I would recommend using one, as it allows the provider to inject anesthesia without any fear of inadvertently moving your needle as you press down on the plunger of the syringe, which is usually directly attached to the back of the needle to inject your anesthetic. Anywhere between 5 and 8 mL of local anesthesia will be sufficient. Using lidocaine with epi will provide roughly about an hour of anesthesia, while using a mixture of 4 mL of bupivacaine mixed with 4 mL of lidocaine with epi will provide a much longer duration of anesthesia, anywhere in the range between 3 to 6 hours. Before any procedure, perform a pre-scan to determine the best point of entry for your needle. You can start at the wrist and move the transducer proximally towards the elbow to visualize the nerve in its entire course. The midform is usually the optimal location. The direction of the probe indicator is based on your preference and comfort level. I tend to choose to have my indicator always pointing toward my or the sonographer's left. Maintain as much sterility as possible, even though the needle will not come in contact with the probe. As mentioned in the previous slide, it is best to pre-scan the entire form and note where you're going to perform the procedure. Then clean the desired site with chlorhexidine or betadine. And to maintain sterility of the probe, you can cover the transducer with a sterile glove filled with ultrasound gel, or you can cover the probe with a Tegaderm, which is pictured above, that I usually get from my IV starter kits. Then I'll use sterile surgical lube instead of my traditional gel between the skin and the probe. I will then visualize the nerve in a short axis plane and approach it with my needle in plane with the probe. Approaching the nerve from either the lateral or medial side will depend on the nerve location and your hand dominance. The best technique is to be in plane with the probe demonstrated here. Knowing the relationship of your probe indicator and point of entry will be important when performing regional anesthesia. If we look at the animation in the top right corner of the slide, we see the needle entering from the indicator side of the probe. The needle is approaching the nerve from the indicator side of the screen on the corresponding image below, and I have it labeled in green. If one were to choose to come from the opposite side of the probe, it would enter from the right side of the sono image instead. It is important to visualize the nerve and any surrounding vascular structures. To help confirm the location of the tip of the needle, inject a small amount of anesthetic demonstrated in the video. Please do not inject directly into the nerve, as this may damage the nerve. Inject posterior to the nerve first to lift it up more superficially, then inject anterior to create that circumferential spread of anesthesia around the nerve. You can see how injecting above drops the nerve and makes it move further away from the needle and more difficult to reach. To confirm good circumferential spread of anesthesia around the nerve, scan up and down the nerve in the short axis plane to confirm the nerve has that halo appearance. Or visualize the nerve in the long axis plane and see how well the anechoic anesthesia surrounds the nerve. Here the median nerve is highlighted in yellow, briefly to aid with this identification, and then you can see I highlight the surrounding anesthesia in blue to kind of accentuate that halo appearance for you. So let's look at the anatomy of the forearm. If we were to slice through this patient's forearm, we would visualize the underlying muscles, fascia, bones, and neurovasculature. In this case, we have a person with a small forearm and can visualize all the nerves of interest. Depending on the body habits and anatomy of the patient, it may be difficult to visualize all three nerves at once, but you may only visualize just one or two of the nerves. The arteries are labeled here in red, and the nerves are labeled in yellow. The nerves we are interested in run along the volar surface of the supinated forearm. Here is a live scan of the previous image. The first structure we identify with directly in the middle of the screen is the median nerve. The second structure on the ulnar side, which I have labeled in red, is the ulnar nerve. The radial nerve is the most superficial nerve on this particular video and is on the radial side or the top left of the screen. So let's look at each nerve individually. Let's start out with the nerve block I feel is the easiest to identify with and perform. That is the median nerve block. Here is another image of the median nerve as it sits in between the flexi digitorum superficialis and the flexi digitorum profunda. The nerve is outlined here in yellow. Here's another image to demonstrate the location and the surrounding anatomy of the median nerve. The median nerve, highlighted in orange, rests in between, like I said in the previous slide, the flexor digitorum superficialis, which I've outlined in green for you, and underneath it, the flexor digitorum profunda, which is outlined in red. So we've identified and understand what the median nerve looks like. We've inserted our needle in plane, as in this case, from the indicator side or the left of the screen, and injected our local anesthetic. Good regional anesthesia will occur with the anesthetic spreading circumferentially and not directly inside the nerve bundle sheaths. To obtain as much circumferential spread around the nerve, which is shaded in yellow, may require more than just one injection of anesthesia. To adjust your needle, do not move or wave the needle around the nerve. Rather, pull back first, then readjust the angle of insertion of your needle before injecting more anesthetic. You are less likely to injure the nerve this way. In my practice, if there is more than half to 66% of anesthetic around the nerve, this will result in good regional anesthesia. So now let's look at the ulnar nerve. Anatomically, it courses with the ulnar artery, traveling inferior with it deep to the flexi carpi ulnaris muscle. Here is an image of the ulnar nerve as it courses through the forearm. As mentioned before, the ulnar nerve, labeled here in yellow, is found medial to the ulnar artery, labeled in red. The ulnar bone is outlined in blue. Please note that a very small percentage of people anatomically may not have an ulnar artery. Here is a video clip of the ulnar nerve as it courses through the forearm. Here's another still image of the ulnar nerve adjacent to the ulnar artery. Here I have two pictures of the typical approach to the ulnar nerve. A majority of the time you will approach the ulnar nerve from the ulnar or medial side of the forearm. Sometimes I find it difficult to inject the ulnar medial side of the arm as is laid supine on the exam table. So one approach that works well for me is to have the patient hyperpronate their forearm with their thumb against the table and their fifth digit facing up towards the ceiling as above. This will make it easier to inject my local anesthetic. Here is a video of local anesthetic being injected adjacent to the ulnar nerve. You can see the needle tip is well visualized. Note I've highlighted the artery in red, the nerve in yellow, and the anesthetic in blue. So let's move on to the radial nerve. This will be the last nerve we're going to look at today. In the forearm, the radial nerve branches into the superficial branch, which we know is primarily sensory, and a deep branch, which is primarily motor. The radial nerve descends through the forearm under the brachioradialis and usually accompanies the radial artery on its course to the wrist. Here we see the radial nerve, highlighted in yellow, adjacent to the radial artery. I've outlined the radius bone here for you in blue. The radial nerve is usually smaller in comparison to the median and ulnar nerves, as its only function is to provide sensory innervation, while the other nerves have both motor and sensory fibers and therefore require more nerve fascicles. Here's an image of the radial nerve in the proximal form. You can appreciate the importance of pre-scanning. You can see how far the radial artery in red separates from the nerve highlighted in orange. This would be an excellent place to anesthetize the radial nerve, as the likelihood of arterial puncture would be very minimal. Again, here is another clip demonstrating the course of the radial nerve. You can see as we move more distally in the form, the nerve courses closer to the radial artery. However, as you move more proximally, you can appreciate how these two structures separate. The best approach to anesthetize the radial nerve is to come from the radial or lateral side, or as some come to call it, the thumb side of the forearm. If the forearm is left in supination, I find it difficult to inject as the table will get in my way. Therefore, a way around this particular dilemma is to have the patient pronate their arm while their thumb is facing the ceiling as above, and this will make it easier for me to approach and inject my local anesthesia to the radial nerve. Here the radial nerve is highlighted in yellow and is being anesthetized under ultrasound guidance from the indicator side of the probe or the left of the screen. The anesthetic is labeled here in blue. To sum up everything we discussed today, I've divided the summary into two slides. The first slide discusses the pearls. Please remember, nerves of the forearm have a honeycombed appearance because the nerves are hypoechoic and the epineurium surrounding it is hyperechoic. Secondly, I recommend that you scan the entire length of the forearm to evaluate the patient's underlying anatomy, as well as locate the best location to inject your anesthetic before proceeding with the procedure. When injecting your anesthetic, you don't want to inject the nerve anteriorly first, as this may push the nerve deeper and more posterior and make it difficult to inject posteriorly, especially if you're using a short needle. Therefore, you should inject posterior to the nerve first, followed by your anterior injection. Also, try to obtain as much circumferential spread of anesthesia around the nerve to give it that halo appearance if possible. Lastly, knowing your sonoanatomy will make the procedure go smooth and simple. In terms of pitfalls, please remember that nerves exhibit an anisotropic effect, so be sure the beam from the probe is perpendicular to the nerve. The nerve may blend in with surrounding structures when the probe is at an angle other than 90 degrees to the nerve. Approach the nerve with your needle at as shallow an angle as possible. Make sure your needle is long enough to reach the nerve and that you have enough anesthesia to spread around the nerve. Too little anesthetic will not provide proper analgesia. Lastly, please remember knowing your sonoanatomy, as tendons can be confused with nerves, particularly as you move more distally towards the wrist. Thank you for your attention. I hope this was informative for you. Goodbye.